Mothers and fathers, grandparents and legal guardians, teachers and childcare providers everywhere. It's my pleasure and special honor to share with you this educational video about a serious psychiatric disorder that affects many children and adults in our societies all over the world. This disorder causes significant distress and dysfunction in the lives of those who have it and also in the lives of their families. The title of this video is Does Your Child Suffer from OCD or Obsessive Compulsive Disorder? My name is Dr. Meher Kazman. I've been a practicing child psychiatrist for over 30 years, and I'm honored to share with you from my experience, my review of the literature, and latest research of what's known about this topic, as well as a spiritual Christian perspective on how to understand it and deal with it spiritually. In this video, we will answer the following questions. What is obsessive compulsive disorder? What is its age of onset and rate of spread? What is the etiology of OCD or obsessive compulsive disorder? What are the features or manifestations of OCD? Do symptoms change in different age groups? And how is OCD diagnosed? What are the evidence-based treatments for OCD? And at last, is there a role for spirituality in dealing with OCD? And we will address that from a Christian perspective. Let's first get to know more about what is obsessive compulsive disorder. OCD is a serious mental health disorder that is widely prevalent and tends to be chronic with devastating impact on those who suffer from it. It's a disorder characterized by a pattern of unwanted, intrusive thoughts, urges, or images that one can control and feels driven to perform compulsive acts to ease his or her distress from these obsessions and compulsions. These obsessions and compulsions also interfere with one's daily activities and cause significant distress and at times dysfunction also in their relationships. But how prevalent is OCD? This disorder affects more than 3 million people in the United States of America. It has about 1 to 3% lifetime prevalence among children and adults, and its prevalence is 2% of the general population worldwide. About 50% of all cases start during childhood or adolescence, and 21% of cases start before age 10. As for child OCD, it usually starts on average around age 9 to 11 in boys and age 11 to 13 in girls, but it is more common in boys than girls. And it's equally prevalent among females and males when we reach adulthood. You may be wondering if OCD is a brain disorder or affects the brain. Which components of the brain are affected and play a role in this disorder? The first component is called the orbitofrontal cortex, or OFC, which is we see here with the arrow pointing in this cross-section of the brain. And the orbitofrontal cortex integrates sensory information for decision making and for anticipating the results of each choice. If impacted by OCD, it's responsible for worry and fear messages formed by mistake. And the second component is the basal ganglia, which includes the striatum, which consists of caudate, and putamen nuclei, and also the ventral striatum. And it is located here, the striatum, in that part of the brain that the arrow points to here in this slide. And if the caudate area is altered or damaged in OCD, it causes compulsions, and that is through the thalamus. Keeping in mind that the caudate as part of the basal ganglia controls movements and thinking, as well as filtering of the anxious thoughts. And that's why this area is responsible for repetitive behaviors or compulsions. As for the third part, which is the thalamus, which is kind of like the arrow points to here in the slide, it is a relay center for sensory stimuli, emotions, memory, and coordinates sensory motor functions. And if the caudate is impacted or damaged, it doesn't control the thalamus, and subsequently the thalamus overreacts, sending strong signals to the orbitofrontal cortex, leading to worsened anxiety and compulsions. So if these areas in the brain are affected, one may wonder what causes these areas to be damaged or affected, or what causes obsessive compulsive disorder. The first set of causes are genetic factors, and research suggests that genetic risk factors lead to changes in cellular function or alters neurotransmitter signals. And these changes disrupt the frontostriatal thalamic circuitry, FSTC, that we see here in the drawing on the right side of this slide. There were two controlled family studies of pediatric patients with OCD that found that lifetime prevalence of OCD to be significantly higher in familial cases compared with control relatives. Also, they found that genetic transmission suggested by these studies to be through an autosomal dominant or codominant means of transmission. The second set of causes are autoimmune factors, and they include, number one, immune responsivity to infections, with group A beta hemolytic streptococci, which are believed to result in inflammation in the basal ganglia that leads to OCD, tics, and or attention deficit hyperactivity disorder symptoms, which are known collectively as PANDAS, which is short for pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. Also, the second factor in the autoimmune causes is what they found as increases in psychological stress lead to the upregulation and proliferation of immature circulating monocytes, which can enter the brain with the capacity to enhance release of pro-inflammatory cytokines, which act to propagate the inflammatory response, affecting the brain function, metabolism, and also the availability of different neurotransmitters. And all of these in turn result in OCD. The third set of factors are perinatal factors. They found that there is some evidence to suggest that perinatal events are associated with a higher risk of OCD later in life. Let's keep in mind this is an associated risk and not a cause-effect risk. So, for example, perinatal trauma is found to be significantly higher in tick-related obsessive compulsive disorder, which is more common in males, especially with early onset OCD. Also, pediatric OCD patients who also have comorbid Tourette syndrome are 5 times more likely to have been exposed to alcohol, nicotine, and caffeine in utero, and about 8 times more likely to have been delivered by forceps. Let's keep in mind that this is an associated risk and not that these kind of elements like alcohol, nicotine, or caffeine, or delivery by forceps cause OCD. The fourth set of factors are brain structural uh, and functional factors. And it's important to understand that is to know that the brain is made of two basic tissue types. The gray matter, which contains most of the brain neuronal cell bodies, forming a thin layer on the brain surface, uh, and the white matter, which is composed chiefly of long-range myelinated axons, which are the extensions of the neuronal cell bodies. And these axons interlink or connect the neuronal cell bodies together through hundreds of millions of white matter connections, which run in bundles deep in the brain. So, and they found that in pediatric patients with OCD, that there is reduced striatal gray matter, uh, while there is increase in that gray matter in the anterior cingulate uh, cortex, as we point here in the slide, and the orbitofrontal cortex. Also, they observed that there is a large thalamic uh, area volume, uh, as well as increased left-right amygdala volume ratio and increased right but not left orbitofrontal white matter in these patients. Also, functional neuroimaging studies in adults with OCD have consistently implicated increased caudate and orbital frontal activity in OCD with alterations of the frontostriatal thalamic connections. Here we see the orbitofrontal areas where there is increased activity and also altered activity on the caudate nucleus here down below. The fifth set of factors are neurochemical factors. And this includes A, chemical balance in levels of serotonin and GABA neurotransmitters and their reduced activity in the circuit pathways between the thalamus and the orbitofrontal cortex. And the second component of this chemical imbalance is increased glutamate and dopamine neurotransmitters activity in the pathway between the orbitofrontal cortex and the striatum. These two factors, as we have shown here in the slide, have been implicated in the neurochemistry uh, changes of obsessive compulsive disorder. But how does OCD manifest and what are its symptoms? OCD symptoms, as the picture to the right of the slide here illustrates, include intrusive thoughts, urges, or images that are unwanted and cause severe distress that drives the child to try to decrease it by engaging in compulsive rituals that are disruptive to his or her daily activities and relationships. And as we see in this illustration here, this girl has thoughts that are very intrusive and uh, uh, cause a lot of anxiety for her uh, as she thinks, I'll get sick if I touch that, or I'll make mom and dad sick too, as we see here uh, on the slide. And these thoughts cause her significant anxiety and distress. And this distress kind of like really drive her to uh, engage in specific either avoidance behaviors with not wanting to touch things that other people have touched, or engage in uh, rituals like washing her hands with a new cake of soap at least 3 times or more each time she touches an object. And these compulsive behaviors like hand washing or checking, and also mental ritualistic rituals like counting numbers or repeating words, are used as a response to neutralize a recurrent obsessive thought or urge without having to have a clear relationship between the compulsive act and what's feared or being avoided. And we need to be aware that detecting obsessions can be more difficult in children with OCD compared to adults. So very young children may be unable to describe obsessive thoughts verbally, but tend to engage in compulsive behaviors with also very limited insight into the excessiveness or absurdity of their symptoms. Also, obsessions and compulsions in children are more likely to change and evolve, as well as uh, increase or decrease in intensity. Uh, they also, in some of the studies done on families of patients with OCD, found that families of pediatric patients with this disorder may have higher levels of anxiety, which is also seen in the child as well. And also, these children have higher risk of comorbid disorders like depression that is associated with increased risk of suicide. Examples of obsessions that we see in OCD uh, are fear of contamination, pathological doubt, violent images, fear of harming self or others, somatic obsessions, which involve awareness of uh, the child's own bodily functions like swallowing, breathing, and blinking. Also, other examples are need for symmetry, aggressive thoughts, forbidden sexual thoughts or images and impulses, as well as religious insults or slurs. Examples for compulsions include washing or cleaning rituals, checking and rechecking on things that the child has done, repeating uh, rituals, also counting rituals, uh, being preoccupied with symmetry rituals and arranging things in symmetrical ways, or ordering rituals, as well as following rigid rituals before sleep or eating, or even before leaving the house. So how is OCD usually diagnosed? First, we need to differentiate between the obsessive compulsive personality type and OCD. Obsessive compulsive personality disorder is a personality type that tends to be rigid, inflexible, perfectionistic, with adherence to strict schedules and attention to details, with also strong desire to be in control. But in spite of that, they are able to function and perform normally and are not bothered by their way of thinking or behavior, which is different from those who have OCD. If your child has any of the OCD symptoms described earlier, he or she needs to be referred to a child psychiatrist or therapist to have a full psychiatric and medical assessment and to see if the child meets obsessive compulsive disorder DSM-5 criteria, which is criteria of the uh, Diagnostic Statistic Manual for Psychiatric Disorders, version 5, and also to see if the child has any comorbid psychiatric conditions. There's definitely a need to obtain a full medical history and conduct a thorough medical evaluation, including neurological exam to assess for any indication of brain insult or injury, or medical condition like infection by group A beta hemolytic streptococci that frequently affects the child's pharynx or tonsils. Also, there's clearly a need to obtain a full family history considering the high family prevalence of this disorder. But we need to keep in mind that there is no diagnostic or prognostic value gained from obtaining genetic or neuropsychological tests or brain imaging studies to establish the diagnosis. Rating scales like the Children's Yale-Brown Obsessive Compulsive Scale may be used to assess symptoms severity as well as response to treatment. And here we see the first component of this Children's Yale-Brown Obsessive Compulsive Scale. Uh, this is the obsessions checklist, and it includes a screening for contamination obsessions, for aggressive obsessions, sexual obsessions, hoarding or saving obsessions, magical thoughts and superstitious obsessions, somatic obsessions, religious obsessions, and also miscellaneous obsessions that do not fall under these category. Other categories like the need to know or remember, fear of saying certain things, fear of not saying just the right thing, and so on. And the last part of this checklist includes uh, listing the top 4 obsessions with their degree of severity starting from the highest to the lowest in severity. And here we see the second part of this Children's Yale-Brown Obsessive Compulsive Scale, which is the compulsions checklists that includes screening for washing or cleaning compulsions, also checking compulsions, repeating rituals, counting compulsions, ordering or arranging compulsions, hoarding or saving compulsions, as well as excessive games or superstitious behaviors and rituals involving other persons, as well as miscellaneous compulsions that are listed here as you see. And also this list includes uh, the task of listing the top 4 compulsions um, with a degree of their severity starting from the highest or the most severe to the lowest severe in terms of how much distress they cause for the child. And then the last part is really how do we score the children's Yale-Brown Obsessive Compulsive Scale. So after the child has listed the top 4 obsessions and top 4 compulsions per each list that we have reviewed, then the child is asked questions as we see on the right hand of this slide here, uh, from 1 to 5 for each obsessions and questions 6 to 10 for each compulsion. And that is to determine time spent on each, also degree of interference, severity of distress resulting from the obsession or the compulsion, ability to resist, and the degree of control over it. And the severity of each symptom is rated on a scale from 0 to 4, with 4 as the highest degree, and 0 is the lowest. And the total score of severity is calculated from the sum of scores for all of the 10 questions. Once your child is diagnosed and the severity of his or her OCD symptoms are determined, it's logical to ask, how can my child be helped? And what are the evidence-based treatments that are available to help my child? In mild to moderate cases, it's recommended to start with cognitive behavioral therapy, or CBT, which is kind of like illustrated here, based on what we think affects how we act and feel, and what we feel affects how we think and do, and also what we do affects how we think and feel. And in OCD, the focus is, as well as we discussed in a previous video about depression, it's changing the way we think has the most influence on how we react to the situations, and also how we behave and respond as well. If parents prefer to start with medication, or due to lack of availability of CBT, pharmacological treatment is offered using selective serotonin reuptake inhibitors, or SSRIs, that are approved by the FDA for use in children. In moderate to severe cases, as well as to the severe cases, recommended treatment is combining cognitive behavioral therapy and SSRI medication from the beginning, which has also been shown to reduce the effective dose needed, and thus also reduces the side effects experienced by the child. And here's an illustration of the role of each treatment modality that we have just described, and how they interrupt the OCD cycle in those who suffer from it. The cycle usually starts with obsessions, which are unwanted thoughts, images, and urges that kind of like causes significant distress and anxiety and fear, with the urge to do something about it, which leads to repetitive behaviors to reduce the anxiety. And when the child engages in that, they get temporary relief until new obsessions or the old obsessions return again. What we see is that SSRIs reduce obsessions as well as reduce the anxiety and distress resulting from them. While cognitive behavioral therapy, or CBT, with using exposure and response prevention, helps the child to learn how to resist compulsions by replacing maladaptive thoughts and behaviors, as well as gradually decrease the engagement in rituals and compulsions through the exposure and response prevention techniques that the child is taught and coached to use. And the cognitive therapy program for OCD is provided to children ages 4 to 18 over 14 weeks and is offered in 5 stages tailored to the child's developmental level. First stage is psychoeducation about the disorder, how it affects the brain, and how the child reacts to these effects and gets conditioned to them. The second is cognitive training to cope with resulting stress and anxiety. The third stage is mapping of OCD with defining obsessions and compulsions and developing fear hierarchy, as illustrated in the picture to the right side of this slide, with first listing all things OCD makes a problem for you, and then to verify is it really OCD, those kind of like thoughts or compulsions or rituals. And also when you make a list of those obsessions and compulsions, it guides the child to kind of like list them and rank them in their severity on the thermometer or the worry ladder, with putting the lowest in severity down below and then moving upwards with the ones that are higher in severity. The fourth stage is gradual exposure with response prevention to each obsession or compulsion, and usually starting with the one lowest in intensity or severity and then moving up the ladder or up the thermometer. And the fifth stage is relapse prevention and generalization of coping skills mastery. And here comes the question, what are the FDA-approved psychotropic medications to be used for OCD in children and teens? The medications with demonstrated efficacy for OCD as monotherapy include 3 well-known SSRIs, which are fluoxetine, fluvoxamine, and sertraline. And also there is a fourth medication that is a serotonergic tricyclic antidepressant medication called clomipramine. First line of treatment is to choose one of the 3 SSRIs because it's better tolerated than clomipramine, though clomipramine is a very effective medication as well. So once an SSRI is selected, you usually start with a small dose to be increased gradually every 2 to 4 weeks until effective dose not exceeding a safe dose limit is reached. The reached effective dose needs to be maintained for at least 12 weeks. If no or limited response, then one of the other SSRIs should be tried. And if no or limited response to the second SSRI, then one may choose the option of either augmenting with an atypical antipsychotic medication like risperidone or Abilify, or to switch to clomipramine alone, and if that's not effective, to combine clomipramine plus an SSRI. But are there any alternative treatments for those who do not respond to CBT plus proven medication? As shown, uh, here are the stages of response to treatment based on a score from the Yale-Brown Obsessive Compulsive scale. And based on that, we determine how people have responded to treatment. So those who are in full recovery are those who are not at all ill, or their score on the scale is less than 8. Those in remission are those whose scale are less than 16. Those in full response are those who had more than 35% reduction of their severity score. Those who are in partial response who have a reduction between 25 to 35% of their scale score. Those who are non-responsive are those who have less than 25% reduction of their score. And those who are in relapse are the ones whose symptoms returned or there is 25% increase of their score from remission level. And those who are considered refractory are the ones who show no change or there's worsening of symptoms with all available therapies. So those who are partially responsive or not responsive, one may consider adding an augmenting medication from the glutamate modulating drugs currently under investigation with limited evidence for efficacy in small controlled trials. And examples of those glutamate modulating drugs are riluzole or N-acetylcysteine, memantine, lamotrigine, and D-cycloserine. But how about refractory treatment-resistant cases? In those situations that have not responded to a combination of cognitive behavioral therapy and proven medications described earlier, one should consider referral for transmagnetic brain stimulation. And this is a modality that has been used successfully for treatment-resistant depression and has been recently found effective for adults with OCD in controlled studies and also for children and adolescents with OCD in small open studies. And as we see in the picture illustrating how this treatment modality is provided is through placing an electromagnetic coil close to the scalp, which sends magnetic waves reaching the deep structure of the brain that are affected by OCD and subsequently helps reducing the severity of the OCD symptoms. And usually those treatment sessions are provided daily, 5 days a week over a course of 6 weeks, and each session lasts for about 40 minutes. And at times there is maybe a need for maintenance sessions to be provided. For parents and caregivers who are spiritually inclined comes the question of what is the role of the child's spirit and if there's any spiritual interventions to help in dealing with this disorder. And what is shared here comes from a Christian faith perspective based on the included biblical references. According to the inspired words written by the Apostle Paul in his first epistle to the Thessalonians, chapter 5, verse 23, may your whole spirit, soul, and body be kept blameless at the coming of our Lord Jesus Christ. And this, as many also agree, uh, means that man has a spirit, a soul, and a body. The body contains the five senses through which man perceives external sensory stimuli, and also includes the different body organs and systems necessary for him to perform his biological functions under the directions and control of his central nervous system. The soul includes the ability to think, to be creative, to respond emotionally, and to make decisions based on information gained and memories stored in specific brain areas. And these areas, if get damaged, the functions that are stored and performed through them become altered or impaired. The third component is the spirit, which is the medium or entity through which man can communicate with his creator, God, and stay in alignment with his will and live in harmony with his soul, body, as well as his fellow creatures. But due to Adam's first and then subsequently everyone's after him straying away from God, this bond has been broken and made man vulnerable and unfit to deal with all life stressors, worries, and fears, which is clearly exacerbated by uh, brain defects that may cause psychiatric disorders, including obsessive compulsive disorder. But God has provided for man the means to reconcile spiritually with Him through repenting and accepting the redemptive work of Christ who died on his behalf, and through the surrendering of man's life to Him. And this is what's confirmed in the words of the Apostle Paul to the Corinthians in his second epistle, chapter 5, verses 17 to 18. We read the words, "Therefore, if anyone is in Christ, the new creation has come. The old has gone, the new is here. All this is from God, who reconciled us to Himself through Christ and gave us the ministry of reconciliation." So those who became believers in Christ can access and receive the truth declared in His Word, which can set them free from fears, worries, and obsessions. And that is through embracing these following facts. First, accepting that faith is not being free of doubt or uncertainty, but by moving forward in spite of them. Second, OCD may try to convince me that fears and doubts are dangerous, but in actuality they are just uncomfortable and can be tolerated. Third, my faith is based on believing God's words and not based on my feelings. Fourth, OCD may push me to think, what if? But responding to this question doesn't guarantee security or absence of doubt. And I need to remind myself of who holds the future, as the illustrated words on the right hand of the slides indicates. Faith is not knowing what the future holds, but knowing who holds the future. And the last fact is that peace with God doesn't depend on how I feel, but on Christ Himself, who declared in the Gospel of John, chapter 14, verse 27, peace I leave with you, my peace I give unto you. And here are some spiritual tips to help any Christian with OCD to deal with obsessions. And again, it's based on Romans 12, verse 2, which is the words of the Apostle Paul to the Romans, uh, as he says, and be not fashioned according to this world, but be ye transformed by renewing of your mind, that you may prove what is the good and acceptable and perfect will of God. And this carries the same principle of CBT, which is kind of renewing our mind, changing how we think about our thoughts and about our life, helps us to kind of change how we react to them and respond to them. And here are those tips to be considered. First, these obsessive thoughts may sound real, but it's not an expression of who I am. The second tip is I need to be aware and remind myself that these are intrusive passing thoughts and I will not fight them, but will keep moving forward with what I do. Third, having them doesn't mean that I am sinful or that I will act on them. Fourth, God knows how disturbing these obsessions are and will give me grace to accept what I'm going through, not respond to them or fight them, but stay in the moment and let them pass through. And fifth, my goal is to starve these obsessions and compulsions without assigning value or meaning to them, reminding myself that OCD is not a sin, and without attempting to respond or make sense of them. Any attempt to do so may make them worse. And it's important to always remember that incorporating spiritual help and tips doesn't nullify the need to use medication and cognitive behavioral therapy if that's been recommended for you. And here is a list of the references that I have used in preparing this topic, with articles from Up to Date as well as from the um, American Academy of Child and Adolescent Psychiatry journal that provided the practice parameter for assessment and treatment of children and adolescents with OCD, and also the Children's Yale Brown Obsessive Compulsive Scale, and also a reference for the spiritual tips coming from the website of www.accounseling.org. For those who have been with us, listening and learning with us in this video, we thank you for staying with us. And if you have any questions or comments, feel free to contact us at ped.psych101@gmail.com, or you may post your questions or comments under this video on our YouTube channel, Know and Grow with Dr. K. Thank you again, and best wishes to you and your loved ones.